Alrighty, hello everybody. I think I've met some of you out there. I feel like I'm like saying how or something. How. I married a part Indian, so I guess it's not totally culturally insensitive for me to do that. Anyway, I'm Dr. Karl Johnson. I've been working at Tri-State for about 2 years now. Before here, I was in Anchorage, Alaska for a little while in private practice. Before that, I was in Houston, Texas in a rear foot specialized foot and ankle residency. So got to see all sorts of cool stuff. Also, the hospital I happened to work at was a bariatric center of excellence, which is kind of weird. But if you've ever seen the TV show, I forget the number, I think it's 500 Pound Life or something. Anyway, that was at my hospital. So at least some of that was filmed there. So in some scenes I'm in the background. I try to stay away, but you know, we got a camera here today, so it's all about me. All right, foot and ankle problems. A lot of you mentioned, you know, I'm on my feet all day. Classic, you know, nurses are usually pretty good about trying different shoes and already have a pretty good handle on what to do. That being said, there's still some new ideas to try and some room for improvement. So hopefully I get around to some of your problems today and you can at least take home one or two things. I tend to talk fast, so hopefully that's not a problem. That's just how I do it. Okay, yeah, so the first thing I want to talk about, extensive time on your feet. What do you do? That's not so much a problem for me. It used to be when I was in residency. Now I tend to sit as much as I can because I hate sore feet. Heel pain, fungal nails, bunions, hammertoes. This makes up the bulk of what I do. I do surgical things as well, but this is probably 90% of what comes in and out on a regular clinic day. And then I'll talk about different shoes, and if you do happen to need surgery, just a couple things to look out for there, okay? So, extensive time on your feet. You have to wear shoes here at work, so, you know, I think I read somewhere in the thing you're not allowed to wear those 5-finger shoes, or you're not allowed to wear Birkenstocks. So they want to keep a certain level of professionalism here, and I think having the right kind of shoes. So one idea that most people don't have is an idea I took from the running community. So runners, to try to prevent injuries that are really common for being on your foot for so long, is they'll cycle through different types of shoes. Some with different, it could be a stability shoe with the exact same features, the exact same intention, but just because it's a different brand, it has a slightly different fit. Maybe the heel's a little more elevated, maybe the width is a little different. So you're exposing your foot to a different stress. The reason why standing all day becomes a problem is you're exposing your foot to the exact same stress every day for hours and hours on end. So if you can mix it up, that's one good way to do that. Another good thing is over-the-counter supports to help the contour of the foot. So you can decrease peak pressures. There was a pretty cool article a long time ago that I read, and it compared a really soft, flat surface to a really hard, contoured surface. And there's something called peak plantar pressure. What would usually cause someone to have a callus or an ulceration on their foot is because there's too much pressure in one particular spot. So almost counterintuitive, the hard surface that was completely formed to the person's foot was a lot more comfortable for the individual than a totally flat one. So find something that fits your arch. Usually shoes are sold to fit the average arch because they don't know who you are before you buy it, and you can't really break that component in. So what you do is have an insole, because there's so many different kinds of those. Try on one that hits you in the right spot in your arch, and that's one good way to go about it. Another thing is you can get custom-made orthotics. Insurances sometimes will cover those. So let's see here. So we talked about that. So if you get just a soft insole, some patients need actually just the soft insoles because as you age, the connective tissue gets a little softer, and there's an actual natural fat pad under the forefoot, and that can shift forward. So where it starts off under the main bones in the ball of your foot, it will actually move forward into that empty space between the ball of your foot and your toes. That's called the sulcus. It'll move into that area and expose all those bones and nerves to a lot of pressure. So they'll get numbness and tingling in the toes and pain there. That usually happens after a certain point in your life, and you'll kind of know when that happens. Then you do need to add some gel. Because I run into that because I see podiatrists just prescribing custom orthotics for the arch support, which will help some. But if you're not doing something to cushion that area, then you have a problem. So memory foam Skechers tend to be pretty good. Those are fairly cheap too. I bought my grandma a couple pairs, and I was her favorite grandson before. Now I'm definitely her favorite grandson. So that's cool. Flexibility is another issue. Not so much from people who stand a lot, but when we not standing, we're sitting, right? We're not sitting in a squat or something. We're sitting in a chair. And when we do that, our ankles are flexed and our hips are flexed. That leads to two issues that generally lead to tightness here and tightness here at your knee. You say, well, what does that have to do with my ankle? There's a calf muscle called the gastrocnemius muscle. It's the one right next to your skin, right under your skin. It's the first one you touch there. And that one actually attaches up on your femur. So it crosses your knee joint. So if that joint is getting tight, and you can tell that because if you straighten your leg out and go to bend at your ankle, you'll feel that muscle stretch. But if you have your knee bent and you go to stretch, you'll feel the stretch down lower just on your soleus muscle. That's because you're relaxing that gastroc muscle, the one that's behind the knee as well. All right, so why does that matter? Well, if your calves are too tight, they'll engage a lot sooner. So when you go to take a step, you're here, there's no calf activity at all. But when you get to about here, your calves will start to engage and load and get ready to push off. So if they're pushing off too soon, you're going to wear out the front of your foot. That's another thing that will lead to that fat pad moving forward. Again, as if you're getting chronic forefoot pressure. That leads to things like Achilles problems, to plantar fasciitis. So there's two main camps in the foot and ankle community. One that says pronation is the root of all evil. And the other one that says equinus is the root of all evil. You say, well, where does that word equinus come from? It's kind of weird sounding. Comes from the word equestria or horses. Horses always run. You don't see them bending their ankle, right? Their ankle's always straight. So if we're walking around more on our toes, like you see little kids who haven't stretched their tendons out yet, they kind of walk around on their toes. That's equinus. So think like a horse, equinus, put that together. So, and we actually have a subset of equinus called gastroc or gastrocnemius equinus. So I hope I'm not getting too technical, but anyway, I feel like I can do that to medical people, even if you're just like working reception or something. Circulation, compressive wear. You're standing on your feet a long time for long periods. You tend to overload the valve structures in the deep and superficial veins in your body. So you have, if you notice already, you have a tube that has a one-way valve. So when you squeeze your muscle, they open up this way and they snap shut that way. So anytime you squeeze, the blood has to go up. But if you're sitting there for a long time, you're not really getting that pumping action of your muscles. Blood will pool up and become uncomfortable, maybe cause swelling if those valves start to fail, connective tissue problem again. Wearing a 20 to 30 millimeters mercury, even more if you need it, will help keep that column of blood heading up north where it's supposed to go, rather than pulling your legs and causing discomfort and cramping in your legs. I get that a lot. One recommendation I have that I've discovered myself is if you don't like to put on the whole sock because it's inconvenient and challenging to put on, go to an online website like Amazon, or here locally you can find a sport compressive sleeve. So it just stops your ankle and goes up to your knee. Without that portion, you just roll it up and you have it like a donut, like a tube. Pop it over your foot, pull it up, takes about like 2 seconds, versus the other ones which your fingers are sore by the time you work those things on. If they've been through the dryer, even worse. I made that mistake. You're not supposed to do that, but I'm like, whatever. All right. Yeah. And then obviously cushioning does matter, but not as much as the other things that I mentioned. So let's get down to the nitty gritty here. When people come in for heel pain, 9 times out of 10, it's plantar fasciitis until proven otherwise. That's just because it's super common. 20 to 30% of what podiatrists treat happens to be plantar fasciitis, so we like to think we're pretty good at treating it. But of course, the heel is a complex structure. You got the sides, the front, the back, the top side of it. So mostly when people say heel pain, it's that bottom part right in the arch. Let's see, yeah. So usually they'll feel a lot of pain right in there, kind of where that red diagram is. And it's on the side of the big toe. That's going to be the apex of pain right there. This little circle should be moved a little bit over and a little bit further up if it was me drawing it. That's where I press pretty much right away when they say, hey, I think I got plantar fasciitis. I push there. They do that little jolt thing. That's how I know they have it. Back of the foot is usually Achilles insertional tendinosis, itis. Why the suffix is changing all of a sudden. Itis typically means inflammation, osis. So it goes from itis to osis to opathy. That's kind of what we call in medicine. There's like the 3 main groups. When you've had inflammation for a long time, the tissues become susceptible to tearing. So they tear, and you might not have inflammation anymore, but you still have the tears there. So scar tissue develops. That's when we change it to osis. So We've done biopsies of both the plantar fascia and the Achilles tendon on people who are brave enough to let people take chunks of their tendons out, and which is crazy, you know. That's why they can never get athletes to do it. They're like, no, really, you can do that on somebody else. And there's no inflammatory cells in there. There's just the scar tissue development. So we know histologically it's not an itis, it's not an inflammation. That being said, there's always a level of inflammation on top of it. That's why anti-inflammatory treatment still seems to be effective. All right. And if you've treated like it's plantar fasciitis and it's still hurting, then it could be a nerve entrapment. There's a calcaneal branch, calcaneal meaning heel bone, that wraps around that side of the heel bone into the foot. And that can become compressed by an inflamed muscle that's right there. And if that happens, then you have a pain that's kind of similar to the plantar fasciitis, so it's misdiagnosed. And that area just needs to be opened up, or the inflammation needs to be reduced to take care of that. That's called a Baxter's nerve, if you ever want to impress your other medical buddies. And that nerve happens to come right through here, and it comes into the foot. So you can see why that would be an issue. Oftentimes there's a heel spur associated with plantar fasciitis. That does not always mean that you have a more advanced case or not. There's a lot of asymptomatic x-rays I see who have heel spurs and they don't really have plantar fasciitis, or they had it a long time ago. I don't routinely remove the spur. Sometimes you can develop an additional growth that will interfere with that nerve or the underlying structures. So in that case, I will remove the spur. There was a pretty landmark article that compared removing it to not removing it. Physicians were blinded to which treatment the patient received, and there was no statistically significant difference between leaving it alone and removing it. Versus, so the other treatment was just cutting the fascia, most of it, and the other treatment was cutting the fascia and the associated bone growth that's inside of the tendon, because that is where where it attaches. It's not like some weird growth for some reason on the outside. That's within the tendon. So the tendon, or I call it a tendon, it's a ligament, it's two bones attaching, stretches. So what is it attaching? It's attaching your heel bone all the way to your toes. And you want to test this out when you get home later. You can show your kids or whatever. Bend your toes up and your arch will compress just slightly. It'll pull your heel bone up just a few millimeters. It's called a windlass mechanism. You pull your toes up, and why does it happen? Well, when you go to take a step, your toes, if you're not wearing too stiff of shoes, will actually bend there, and that'll pull your heel forward, forcing you into a supination or a locked foot type. So you go from a flat foot to an arched foot just by that subtle movement. So that's pretty cool. Body's kind of thought of everything. So I don't know why it gets hurt all the time. All right, probably because we're doing really unnatural things like standing all day. You know, I don't see animals doing that. Anyway, well, I haven't paid attention. All right. I was like, well, horses, they kind of stand a lot. So, all right, bottom of the foot, plantar fasciitis. All right, when I treat somebody, I want to see what they've done, so I break treatment into 4 different categories. These ones on this side I call short-term. Those ones I call long-term. The reason I call those long-term is eventually you got to phase out this stuff. You can't always rely just on the short-term items, or you run a high likelihood of the plantar fasciitis returning, or you just become dependent on them, and as soon as you remove those things and try to do something else, your plantar fasciitis will come back. So first thing I do is try to control the inflammation, because if I'm going to have people stretching and strengthening that area, they're not going to do that if it hurts to do that. Plus, I want to get them back to their activities, start enjoying life. It's kind of difficult to do that, because if I take care of all the pain, usually people say, well, that was a bad dream. I'm just going to go about my merry way. So I just have to emphasize, if you want to keep coming back and getting the shot or whatever, you can do that, but I recommend looking for the underlying cause, or this is going to be something you might have to deal with later. And there's consequences too, because as you see, if it tears, it stretches out, you lose that function, you might have a flat foot after a while, or you might tear the plantar fascia. I see that happen all the time. People were doing burpees or something in the gym, they felt a large pop, super sore in the foot, pain went away, but now their foot's flatter. So now they're going to get ankle pain, so that's not good. Yeah, so sometimes I give people either an NSAID like Advil, ibuprofen, or I give them a steroidal drug like Medrol, methylprednisolone. So that's an oral steroid for a week, or an injectable steroid like Canalog, different kind of cortisones we can use. Pretty much all have the same long-term effect. For plantar fasciitis, a cortisone shot, if done correctly, will last on average 3 to 6 months, depending on the level of pain the patient's already experiencing. Some people, it's even up to a year. So I've seen that, which surprised me. The next category in the short term is usually what gets the most emphasis, and that is support. So we're looking at shoes, orthotics, taping, compression, bracing, that kind of stuff. When I say shoes, what is a supportive shoe? I get a lot of different feedback on that. And unfortunately, there's a lot more shoe options than ever before. You'll see these Nike free ones. If you look on the bottom, they have all these cross hatches in them. They're super flexible. That's great because I think it allows you to strengthen your foot. However, if your foot's not used to it, or it's just not used to standing on it for 12 hours, then that's not the ideal shoe for you. And you probably shouldn't be wearing that. You want something that does not fold in half, so you can't fold it that way, or if you do, it only bends a little bit on the toe section where your toes bend, but not in the arch. You don't want the arch to bend. And you want to grab it this way and kind of bend it like that and make sure it doesn't have that torsion effect. And last but not least, you want to flex down the heel cup and make sure that doesn't collapse easily. And the reason for that is if you have the first two features but not the last one, your foot has a tendency to move independent of the shoe, and you want that support that's in the shoe to support the structures in your foot. So I'll see a lot of these sandals that just have a strap over the top of the foot, have a nice contoured footbed, but don't have that heel in the back, and that's just getting 2 out of 3. Say, it's better than flip-flops, right? Those are like the worst thing ever. But anyway, I don't know, that sounded really dramatic when I said that. They're not the worst thing ever. I don't know what the worst thing ever, probably like pump high heels or something, but they're just too darn cute, so we got to keep wearing them. Anyway, so insoles. I mentioned over-the-counter insoles. I like ones that aren't too flimsy. Sometimes you get them that are just foam. You can start with that because they're cheap. Start with the cheap options, move your way up. Don't have to go down to, I don't know, Good Feet store and spend $500 on over-the-counter insole. Don't recommend that. Start with the $8 over at Walmart. Slap that in the shoes. Give it a week. See how your foot adjusts. If you need to move up from there, move up from there. Or if you just want a decent one right off the bat, $45, $50, go to, I was going to say Tri-State Outfitters, but I feel like I heard they're going out of business, so don't go there. Or maybe go there. I don't know. I think that whether or not you give them your business, I don't think it'll change that. But anyway, Super Feet, not a bad brand. I recommend trying them on. Don't just buy them online because they have several different kinds, an orange one, a green one, a pink one. They all have the arch in a slightly different position. I happen to like the orange one. So that's what works for my foot. That's what I've worn in the past when I've had foot problems. But then after about 3 months, I taper those out where I only wear them instead of every run. You know, it's 3/4 of the runs to half the runs to whenever to never. You know what I mean? Compression, I mentioned that earlier, but this is a different kind of compression. You can find compressive socks that will actually squeeze the entire arch construct together. And that's good because you're pulling that fascia up and allowing it to support the arch without having the muscles to do that work. And then finally, taping. If you can buy kinesiology or KT tape, it has that stretchy kind of factor to it. I like that. I anchor it on the forefoot, kind of right here. I should have this on the diagram, but I don't. And then because it's stretchy, you give it about 80% pull, so not quite 100% because it'll pop off too early. But give it a really good stretch and then just go straight down the angle up the Achilles tendon. That's a good way to do it. And then put a couple on the sides. If you don't remember that, which you probably won't, you can look it up online, just KT taping for plantar fasciitis, and you'll probably see something similar to that. All right, next category. So strengthening, what can you strengthen? Because the calves are getting too overused and the front of the shins aren't getting that used, so you've got to work on strengthening the front of the shin or the tibialis anterior muscle. If you really want to get specific, it's the muscle that bends your foot upward. You can do that with one of those stretchy resistant bands. You can get a kit for about $9. You look online, that's about what they run for. And what you do is put that under a bedpost or something, put your foot under there, make sure it's not going to come out and smack you in the eyes or something. So when you pull on it, you get that action there, and write down how much you could do, and then try to double that in a month or something. The reason I put the glutes on there is the excessive standing tends to lead to weakness, which allows your legs to rotate inward. So you get the knob knees coming inward, and that also leads to flattening of the feet. So the plantar fascia, which is trying to keep your arch up, is being overused because of that poor foundation up here. So strengthen everything back there, you know, incorporate some body weight squats, or if you're getting in the gym, barbell, that's the best way to do it. And then foot muscles, that's kind of weird, you know, the really small muscles of the foot that allow you to flex your toes down. One of the other problems of wearing shoes, we don't use our toes very much when we walk compared to what we should be doing. So if you want to strengthen those out and support your plantar fascia, get a towel or other fabric that you can curl up with your toes, just allow some resistance. I've had patients even set something on the towel once that got easy, like a water bottle or something. So when they're pulling it against a smooth surface, you actually curl your toes until there's just too much material under your toes, and then step forward, curl, curl, step forward, curl, curl. It's kind of how they do it. And then once the whole thing's balled up, you just roll it out and do it again, and you're done. So it's not bad. Calf stretching. Oh, let's see here. I think I got a slide for that. Yeah, this is the thing that I like to do on the left here. I don't recommend doing the stairs. You see a lot of people recommending that. I find people overstretch and can injure their Achilles tendon that way. I like to be a little more gentle, a little more controlled and consistent with it. I think consistent stretching after you're warmed up is better than a whole lot of stretching all at once. So kind of avoid the stairs if you're going to be stretching. Well, let's see here. Yeah, if you have knee problems, don't fully extend your knee when you're stretching. You could exacerbate a patella issue here on your knee. I haven't seen that a lot, but I've heard that can happen. So just in case that's you, I don't want you to get hurt and blame me for it. Yeah. Okay. If you feel a lump in your Achilles tendon, there's two different kinds of lumps. There's an inflammation around between the tendon and the thing called the peritoneum. You could think of it as a sheath that has a lubricant in there. So when the tendon's moving up and down, it doesn't cause friction. All your tendons have something like that. If you really want to be technical, it's not a tendon sheath. We call it peritoneum. Anyway, people like to geek out over that stuff. It doesn't really matter. The fact of the matter is, if you grab that area and move your tendon up and down, and the nub moves, you can feel it moving under there. Like if I had this and I was moving it between my fingers, right? That means the lump is actually within the tendon substance, and it's predisposing you to an Achilles rupture, which is not good. My father-in-law had an issue before I went to podiatry school, and he was playing basketball or something with a youth group, and he started yelling at the kids because he felt a snap there, and he felt like somebody hit him in the back with a stick or something. I was like, I don't know. So who did that? And he was by himself, and they're all like looking at him confused. And that's what it feels like. So if you see that lump there, you don't have to totally freak out. Most time it's not the actual tendon. It's between the tendon and the tendon sheath. It's inflammation there. But sometimes it is the actual tendon itself. I had a lady when I first started here come in, and she had this issue. She had another doc who wanted to do surgery on it. I said, well, let's try some strengthening exercises first. She had a gym membership, so I showed her what she could do on a foot press, you know, stick it out there. What I had her do was push down with both feet and then remove one foot so that the injured side would take that pressure on the way down. That's called an eccentric load. It puts more strain into the tendon in a controlled fashion. And I had her do that 1 day on, 2 days off. So she would go to the gym, do it kind of aggressively for 1 day, and then protect it for 2 days. Those 2 days off are critical because that allows for those micro tears and things to realign and get that tendon stronger. So her symptoms were gone in a few months, and then she was able to, she had other things on her plate, like she had a total knee replacement, you know, and didn't want to have to do an Achilles thing on top of that. So she was able to avoid surgery from my perspective, and I thought that was cool. So I was thinking about that. Yeah, so that is an option. But there is another kind of Achilles tendon problem where it attaches to the bone. And just like the plantar fascia that can tear off the bottom of the bone, the back of the heel bone has the Achilles tendon, which is the largest tendon in your body, probably for a reason, because whoever had a real small tendon back then tore it and died. So it'll kill you. No, I'm kidding. Or got eaten by the lion or something. Anyway, so it develops over time. It slowly develops this bone spur that's actually inside the tendon substance. And it looks like a little spike there, but it's actually a shelf. So if you look at my hand like this, from the side it looks like that, but you look at it from this angle, and it's a big old shelf. So if conservative therapy doesn't work, immobilization, strengthening, that kind of stuff, stretching, if that doesn't get any better, and you got a big lump there, and it hurts on your shoes, it hurts when you got activity, then what I'll actually do is make an incision right in the back, in the OR obviously, and open that area up, scrape the tendon off, get rid of all that. So I'll just come in here and just shave a nice contour, a nice anatomic restoration there. Remove that all out. Any scar tissue or bone that's sitting in the tendon, because sometimes they'll have another chunk just floating up here. So I'll go in there and remove that. And then with a 4 anchoring system, put it all back together. And it's a pretty sweet product, came out from Arthrex, and their pamphlet says by their research that you can walk patients immediately after surgery. I feel like they're kind of getting a little carried away. It's a little heavy marketing, so it makes me nervous. So I still do at least a couple weeks of non-weight bearing and then start in a boot. So that's great, because the traditional treatment took 2 months rather of complete non-weight bearing, and that's just crazy. So the anchors have come a long way and are really sturdy, and you can tell when you're in the OR. Because sometimes when I was in residency, we would repair a tendon and be like, nobody touch it, like, oh, I don't want it to, that's not good. You want to be able to work that thing, because, I mean, imagine when somebody's standing on it, it's going to get a lot more force than what you could do in the OR. So I think you're doing the patient no service if you can't repair it in a real good way. Yeah. Physical therapy works better for the non-insertional, and like I said, insertion means the tendon plugs into that bone. That's what the insertion is. So if it's up in the tendon substance, I'm emphasizing heavily the stretching, strengthening, and I'll do the same for the insertional, but it just doesn't work as well, I've come to discover. And it's probably because there's just the tendon itself is compromised. It's not supposed to have bone inside of it, and you can see that. Yeah. What do you got over there? I talked about that already. Yeah. So, if you ever heard of carpal tunnel, there's a similar thing in the foot called tarsal tunnel. So these are carpal bones and metacarpals. Well, the same thing in the foot. There's tarsal bones and metatarsals. And so the tarsal tunnel's on the inside. Sometimes with flat-footed individuals, they'll get swelling and inflammation in that area, and will pinch off that nerve that goes to the bottom of your foot. You get a lot of pain there. I haven't had to do this in a while, actually. I do a referral to a neurologist, does a nerve conduction velocity, because if a nerve's getting squished, the signal doesn't go through very well. That's why if you sit funny or sit on the toilet looking at your phone for an hour, if you ever done that to like escape the kids or whatever, anyway, your legs go numb. Pressure, not good. That's because the signal's not getting through. You've done it. Anyway, one time I was doing construction after high school and I fell asleep on the toilet, and I woke up and I couldn't walk. It was bad. I was like, I need more sleep. Anyway, not a good place to fall asleep. All right. That's a good segue to fungal nails. Fungal nails, big problem. Dr. D's here. He loves talking about fungal nails. I wish I could turn the time over to him, but I put him on the spot. He pointed out a very good thing, because we do a lot of wound care, and fungal nails, you don't want those contaminating the wound, so it's very important to treat and manage those. However, in our younger, healthier population that's usually not dealing with chronic wound care, fungal nails can be misdiagnosed. Oftentimes a patient will come in, they have tons of claw toes, they say, Doc, I've tried all the fungal treatment, nothing's working, what do you got for him? I'm like, well, sorry, you tried all that treatment because you don't have fungal nails, you just have thick nails because they're hitting the inside of your shoe. I pull the insole, that little liner in your shoe, I'll pull that out and show them, and they've rubbed little holes in all the toe spots. There's like rub little holes there. I'm like, oh, I didn't know I was doing that. They're like, maybe I thought I was wearing too tight of shoes or something. I'm like, no, your shoes are plenty long. It just doesn't matter if you wear shoes because your toes actually will do that. So too much trauma to the nail can also make them look thick. It'll thicken that plantar nail plate that's in there. That's not the same thing. If there's a doubt, there's tons of different cultures and lab tests we can do. A simple lab test that I do is the KOH stain. I send that over. It's immediate. They don't have to culture it, and they tell me if there's fungal or not. Sometimes insurances want that, so I can put them on a oral medication. Given the liver problems, there's a great drug that's been around forever, Lamisil. You've probably heard of it. Works pretty well. There's other things I do when I have people do that. One, I make sure they're changing their socks. You'd be surprised how many people don't actually change their socks. It reminds me when I was like, 6 or 7. Yeah, right. I was like 6 or 7 years old, and I'm kind of particular about stuff. And I'm like, I got all the hand-me-down socks because I'm the youngest, and they were all kind of worn out anyway. And so I was like, I love these socks. I'm just going to wear these socks every day. It's going to be great. And yeah, it took 1 week to me realize that's not a good idea. So I got a real bad case of athlete's foot, and I was like, that was not good. So that was probably one of my first encounters with a podiatrist. I didn't even know what a podiatrist was. So he's like, all right, put this fungal cream on your feet, sleep with socks on at night, so it gives it time to treat it. I give people the same lecture I got 20 years ago or 30 years ago or whatever. Sometimes with fungal nails that can be really stubborn. The ultimate treatment is to remove the nail, like actually take that sucker off there, put a topical treatment on there, and do the oral medication. So that's like the trifecta, you could say. And we do that. Unfortunately, you have to put the topical on there for about a year, because that's as long as it takes for the nail to regrow from point A to point B. And if there's fungal, yeah, it sucks. The problem with fungus is, unlike bacteria, we share too many characteristics with a eukaryotic organism. You remember that? Going way back into those files. And so unlike bacteria, there's not so many differences to exploit without hurting our own native tissue. So we're kind of stuck. Don't use lasers. Those were touted as the miracle cure for fungal nails, but what they really seemed to be the cure for was light wallets for the physicians using them, because it costs like $900 to $1,000 like per treatment. I was like, okay, some people really want to get rid of them fungal nails when it's just about as effective as like tea tree oil or Vicks Vapor Rub or any of the other home remedies, which are about 15 to 20% effective. So anyway, that's enough about that. Something more exciting here. Let's talk about bunions, huh? What is a bunion? You raising your hand? You got those? Oh boy. Sign her up. All right. Put her on the schedule. No, I'm kidding. A lot of people have bunions. My mom's got terrible bunions. I got her feet, but I didn't get her bunions. So it's more common among women. It is. Women are more flexible in the foot and more tight in the calf, so it's a double doozy. That, or they just come and see foot docs more often. I don't know. They're smarter about seeing doctors that way. They're not too proud to ask for help. All right, where am I at? So bunion does not mean bump on the foot. I get a lot of people say they got a bunion. I take off the shoe. They got like a lump in the middle of their foot. I'm like, sorry, that's not a bunion. That's probably a ganglion cyst or bone spur or something else. So just to make that clear. When you say a bunion to a foot doc, we always think it's on the big toe. Big toe's moving out. The big toe bone moving in. This metatarsal bone, if you put on your x-ray goggles, is right here, bends inward, okay? Inward meaning between your legs. And when that happens, your toe moves over. It's not a growth. Some people think, can you just shave it off? I'm like, well, yeah, if I want to take off half the joint with it, I could do that. Oh, do I have a picture? Yeah, well, anyway, I think you can kind of get the idea. I have a straight arm, I bend it like this. That's not a bump, that's my elbow. You shave that off, I got no elbow. That's what people tell me to do. Just shave it off, man. I'm like, no can do. And actually, what's kind of interesting is you see it on x-ray and you're like, whoa, look at that thing, it's way out there. Well, it's not just that, but it's actually rotated a little. It's rotated like that. So when I put it back, I got to do that. I can't just push it over because it's still going to be, you see how I'm rotating a little bit? Well, that bone rotates, and so you need to rotate it back a little. The reason for that is if you don't do that, 80% have been shown to reoccur in up to 2 years. So that's not good, because usually people don't retire in 2 years. You're going to see them again, and they're going to be mad. So that's what I think. I'm like, I don't want them to come back and be like, hey, what? And I was like, shoot, because it's not a fun surgery to get. You got to be off your foot for a period of time. You get a lot of swelling that can last for a year. People don't like it. So I'm not trying to sell you on bunions. I just want you to know what you're getting into. All right. If you have a Taylor's bunion, it's spelled Tailor. We got after a resident who kept spelling it like Taylor Swift. We're like, dude, it's not Taylor Swift bunion, okay? I had a dream once that I did foot surgery on her, and I was like, what the heck? I can't screw this one up. This will not go well. Anyway, it was a nightmare. It happened. This picture doesn't really have Taylor bunions, but it's the same thing, just on the fifth bone here. I get into this argument all the time when I schedule a person for Taylor's bunion. They're like, well, where is it? And I forget that not everyone knows that it's on the fifth metatarsal. So I'll just say bunion deformity, fifth metatarsal, or bunion deformity, first metatarsal. I don't want there to be any confusion when you're dealing with consents. You know what I mean? You got to try to be as obvious as you can be. So I got to think like them, not like me. Obvious first treatments here. Come on, save yourself some surgery. Just wear some wider shoes. People say, well, I got this V-shaped foot. I'm like, well, yeah, you do, you know. So that is a bummer because not a lot of shoes come looking like a triangle, you know. Like, hey, you know, your heel bone doesn't spread out with age usually, but your forefoot does. Yeah, so I'll have a patient, I'll pull out their insole on their shoe and have them stand on it, and you see about that much on both sides popping out. I'm like, okay, that shoe's too tight for you. Let's get you in an appropriately fitting shoe. I'll measure them, give them some recommendations, tell them, hey, before you buy the shoe, don't look at the size. Don't be obsessed about that. Go a little wider. Pull that insole out. If you don't know what insole is, there's a liner in most shoe brands except for Nike and Skechers. I don't know why they felt like gluing them in there. They don't move. You don't need to glue them in. They got too creative. I don't know. They just want to make it a hassle for me to tear them out, which I do, only after asking for permission. People get mad if I just start, Grr. Anyway. Take them out, stand on them. You know, you got your socks on, you're going to try the shoe on anyway. Don't go through the hassle lacing it up to find out it's too tight. Just pull that thing out of there and stand on it. You know, if you're getting tons of spillage over the sides of the shoe's not wide enough. You got to go up, okay? And you can't say, well, 9 and Asics is the same as a 9 and New Balance and Nike and all that because shoes run a little different. Their lasts are different. You know, there's a lot of variables to look at. So just actually try that on first. So splinting, if the bunion's not too bad, you can do that. But often these like miracle cure bunion splints you see being passed around on Facebook, they don't do so good because you'll actually dislocate the toe and have it grind in a way that's not good for it. So mild bunions that are flexible, have at it. Severe bunions that just won't reduce with minimal amount of tension, don't do it. You'll end up hurting yourself. But you'll know that right away, so I don't have to preach on that too much. It'll be uncomfortable to wear. Surgery is a very common thing we do to fix this. I typically address the joint that's in the middle of the foot. That's where the bone is actually shifted over. So by doing it there, I can address all three problems, the sagittal, transverse, and frontal plane. Sagittal is this motion, transverse this motion, and frontal plane is this one, so it's that rotation I was telling you about. You got to fix all those or you run the risk of it coming back or still having a lot of pain afterward. I don't want to get into too much detail, but that's how I do it, and it just adds a couple weeks of recovery. And some certain risks, the joint may not fuse as well, so I'm a little more cautious of individuals of advanced age or a history of smoking or diabetes, but you know, that's caution anyway. Okay, it is important to stretch too, because if you think about it, people are like, well, what is the mysterious cause of bunions? I don't think it's that mysterious. I think it's chronic forefoot overloading. Chronic forefoot overloading. So you push your foot down, and the foot bones, you can see this in slow motion capture, will actually spread out. You know, they do that. Well, our foot used to look like our hand. You see how our hand does that? You see monkey paws, you know, they kind of look like this. Well, a long time ago when we decided to stand up on our feet, we did this. Well, there's no real ligaments between here, so that's why this falls back out and causes a bunion. So when your calf is too tight, that just happens real fast. Those areas will spread out, causing bunions. So keep your calves nice and loose. When people say bunions are hereditary, something you inherited from your parents, like the color of your eyes, your hair, and all that, well, you're predisposed to get bunions, and it's not saying you have to get it, you know. It's not like eye color, you know, there's nothing you can do about that other than wear contacts or something silly. But stretch your calves out. That's probably the trait you're inheriting. Or your foot is too loose, so maybe wear a comfortable splint early on if you start to see it happening, you know, those sort of things. So it's not like, well, there's nothing you can do about it, just sign up for surgery. I get that a lot. All right, hammertoes, another thing. Hammertoes can come from a variety of problems, neuropathy, flat foot, tight calves, because if you think about it, if you got tight calves and you go to bend your ankle up, the same muscles that attach your toes also help you bend your ankle. It's not like you got one muscle for one function. Like the body doesn't work like that. It'll often use one muscle for several functions that work together. So the same muscles that bend your toes up are also responsible for helping bend your ankle. So if they're having to work extra hard, the balancing muscles that are on the bottom of your foot get overloaded because they're weak, and your toes will just start contracting like that. So that's one way to get it. Another way to get it is if you're flat-footed, your tendons are trying to do what your ligaments and your tendons, or your bones rather, should be doing. And if those are out of alignment, then your tendons have to work extra hard You might get cramping in the leg because that's where the muscle starts, or in the foot. I see that a lot. And then you'll get hammertoes that way. So, and if you had a hammertoe long enough, they get stuck like that. Either the skin will get shorter or the joint itself will just freeze up, because around every joint there's a little bit of connective tissue, and if that gets short, you're not straightening that thing out unless you pull on it for like a year straight, then maybe, with like a splint or something. So if you're getting pain on the tip of the toe because it's doing what I said earlier and just rubbing holes in the bottom of the shoe or in the inside of the insole, then something like a crest pad, that area under there, that sulcus, we also call it a crest. If you can elevate the toe somewhere else where it handles pressure better, then you don't get pain on the tip of the toe, something we give out in clinic on a daily basis. So that just wraps around the toe here, lifts all the toes up so they're not rubbing on the bottom, in the insole. Works pretty well. Doesn't require surgery. The next thing I like to recommend, if the toe is a flexible hammer toe, meaning if I pull on it, I can get it straight and it just springs back like doink, doink, I'll try to decide which tendon it is, because there's a short tendon that starts in your foot and there's a long tendon that starts in your leg, comes down and attaches. The long one goes long, the short one goes short. So anyway, it doesn't really matter, but the end result is I'm able to fix a hammer toe, same day appointment. I used this example this morning. I had a patient yesterday afternoon. Nice lady, came in, not a good surgical candidate. So what do? She's got this horrible, she called it a callus, but really it was pre-ulcerative, meaning I could see bleeding under there. The whole area was turning white and blistery, meaning there's a high likelihood of this area breaking down and the bone popping out and then running for, the risk for osteo or bone infection. And then that's a bad cascade. You run the risk for amputation. So I said, well, what's a good definitive thing I can do with her that's not going to expose her to much risk? And that is something called a tendon release. So I'll numb the toe. Doesn't take very much, probably 2 cc's lidocaine to do that. And then put an 18-gauge needle, which sounds kind of crazy, but it works, under that toe, and then swipe it back and forth. You can really feel it like you're strumming a guitar string because it's really tight. So I just give the toe a little tug, swipe that thing. Takes a little bit to do that. Pop the tendon, the hammertoe's deformity is gone, and it doesn't come back. And so that's pretty cool. That little incision spot, because it was done with a needle, heals in about a day or two, and they're done. I see him usually a couple days after. I originally did that just for neuropathic diabetic patients who had this problem because they don't know when to back off because they just keep walking and walking, and then they rub a hole in their toe. Versus us, we go, ooh, that hurts. I got a blister there. I got to figure this out. Wear softer shoes, something. But I've had so much success with it in the diabetic population that I started doing it on just anybody, and it works really, really well. I haven't had anybody be like, oh man, I really miss the ability to pick up pencils or stuff with my toe, because that toe's gone. You still have the other ones, and that toe will move a little bit because there's other muscles like lumbricals, but usually they're like, hey, this is awesome. I can finally wear the shoes that I couldn't wear forever because it was rubbing in there, and I just had to wear these thick, they call them grandma shoes. I had a younger girl said she would start running and she would actually trip on the toe if she was not wearing shoes. I'm like, that's kind of crazy, but hey, it happens. The last thing is, if I can't do that, and let's say I'm fixing a bunion at the same time, so I'm able to bring right in the OR, I'll actually remove a little portion of that joint. This joint that's right there, I'll actually just cut that out, that cartilage and everything, and that shortens the toe a little bit, because you remember that skin's usually tight on the bottom, so I can't just straighten the toe, because if I do that, it'll close off the vasculature and the toe will turn black. I've seen that happen, So that's why I make sure after I take the tourniquet down that the toe pinks up. If it doesn't, you watch it for a while. If it still doesn't, then you gotta undo that, because I'd rather have a hammer toe than no toe, Haven't seen that happen though, but that's in the literature, so I'm always looking out for it. I don't want that to happen to me or the patient. Yeah. So I usually don't use a wire in that case. The traditional technique was to use a K-wire, but the problem is you get no frontal plane control, so sometimes the nail will slowly drift one way while it's healing. That looks weird to have all the nails kind of up like that and then one that's off, and people like that. Plus there's no compression from a K-wire. It takes longer to heal. You got to be real careful with the repair. Make sure the ligaments are nice and tight when you sew it together. Make sure the dressings are done perfectly. It's really fragile kind of thing to do. I used to hate doing it. But there's a great implant that I use now. My watch is telling me to move, so I got to do some jumping jacks. Hold on. There's cool implants that will actually snap together. Usually they're, the one that I use comes really cold. Put it in there, hold it for a couple minutes, and then it expands and pulls the bones together. You don't need to know that. Long story short is there's no risk for pin track infection. I did have one case where I did need to put a wire in a guy because he had so much deformity I needed to straighten out the entire toe. But he was walking around earlier than he should be. He loves his locksmith business. He didn't want to let somebody not open their safe, I guess. So he went over there and did that. But the wire migrated out of the toe from walking around. And he came in, the wire was popping out. I'm like, well, thanks for not pushing it back in there. People will do all sorts of things. I know. So we had to pull it out and then just splint the toe like he came in with a broken toe, which I do see a lot. So I just splinted it like he had broken it. You know what I mean? So his repair might not be perfect, but he didn't appear like he was too concerned about that anyway. All right, we've been talking about shoes the whole time. I did a little Googling, see what was out there, and I found an article that seemed to have some good stuff, so I took the best of it and put it on here. Oh yeah, that one's straight from me though. I don't know when he talks about that. Just pull the insole out and step on it. That way you know if it's wide enough. Daily use, please don't wear anything where the heel is 2 inches more than the forefoot. So I don't think that's a major issue around here, but there are some shoes that are touted as good shoes for walking in all the time, and they have quite a bit of a heel, which I find amazing. So try to avoid that. Shoe companies are better now about telling you how much thicker the heel is than the forefoot. Standard, Asics, New Balance, Saucony, Reebok, all those, standard is a centimeter thicker than the heel. That's because if you're walking or running, people typically impact their heel first, so that's where they want the most shock absorption. They're always trying to sell the next shoe, give you a reason to buy another shoe. So obviously, if your feet tend to swell, try them on when they're swollen. I finished a marathon. I did the Des Moines Marathon when I was going to school there. And I'm like, man, why are my shoes so tight the next day? I was like, oh, my shoes aren't tight necessarily. They're only tight because my feet are super swollen. Man, that was rough. I was not in good shape when I ran that. All right. Try on both shoes and buy for larger foot. It's not unusual for us to be a little asymmetrical. You notice that sometimes people have a leg that's slightly longer than the other. Well, sometimes you have a foot that's slightly longer. You don't want to buy accidentally for the short foot. If you know that's you, make sure you get it for the long one. You should be able to slide your finger in the back of your shoe. If you step down, kind of squish your foot forward a little bit, you should be able to slide that finger back in there. That gives you about a 1/2 inch clearance in the back. That allows for your foot to expand as you walk, Okay. We're getting close to the end here, folks. People don't like to talk about surgery, but so many people end up getting it that I think it's good to at least know what you're getting yourself into. Probably the most important thing is to make sure that you have a clear understanding and the surgeon has a clear understanding of what you're expecting and what they're expecting. Because sometimes I think the surgery turned out great, but they're like, yeah, but it's still swollen. I really don't like that. I'm like, well, maybe I didn't do a good enough job talking about how there often is swelling in the feet. The feet happen to be at the bottom of a long food chain here, and gravity tends to not really help the foot. I talked about those little valves in the foot that push stuff back up. Well, those don't really kick in until about the lower calf region. So what does get blood out of the foot is the walking motion. And if you're not walking out a lot because your foot's still healing a little bit and it still hurts, then you're not able to flush that out. I saw that for myself one time. Kids were arguing with mom, and I was already frustrated with something on the computer. So this was a few years ago. I ran out of my office to go yell at the kids, hit my foot on the door, and broke my fourth toe pretty bad. And yeah, that was back in residency. I put my foot up on the X-ray machine. I was like, oh yeah, it's broken. And splinted it. It took forever to heal. But impatient me, I went for a 10-mile run. And it was super swollen, when I started the run. And when I was done, the swelling was gone. I was like, hey, that's cool. Look at that. But the swelling came back soon after, so it wasn't done healing, you know what I mean? I think about that all the time because I'd heard that, and now I finally experienced it for myself. Yeah. So here's something you should get is just a general outline of when can I do what. Because there's a lot of people come out, and even though we've gone through this, they'll ask, hey, so I can walk now, right? Like, I'm cool to walk, you know? That's usually the first question. I'm like, okay, not yet. Just refer back to that form I gave you. They're like, what form? I'm like, oh, boy. Yeah, they're kind of drinking out of a fire hose when they're talking to me. I think it's just like one of those little playground drinking fountains, and it's hard for me to see it from their perspective. So I'll say something like, if I'm removing an ingrown toenail, I'll say, well, this procedure makes it so that the toe nail will not grow back. I can put a chemical here to keep it from growing back. And they'll be like, okay, yeah. And then I'll see them next visit after doing the procedure. They sign the consent. I explained all that. I drew a picture on the whiteboard. Your nail will look like this, show them a picture of it. And they're like, so when's this nail growing back? I'm like, oh, I didn't do a good job teaching about the fact that it's gone for good. So, it's kind of hard to break them that news. But if you do get a nail removed, it does take about a month to know, if it was successful or not. It takes about 9 months for a complete great toenail to grow back. Some people it's up to a year. Some people it's a little faster. Hey, here's a fun fact. Did you know that each nail on your finger and on toe has a different rate of growth? So it's kind of fun to know. I learned that several years ago sitting in a pediatric office. It came up on some did you know board. I was like, oh, I didn't know that. Well, here we are. All right. Yeah, so I did an ankle fusion recently. This is kind of what I gave them, but I had dates associated with it. And I try to be a little more conservative so that people aren't disappointed when I tell them they got to be longer. They're a little excited when it's a little sooner. For example, a guy I did recently, I was able to get him out of the cast 4 weeks ahead of schedule because he was healing faster than I expected. I tried a new graft in there, osteobiogenic graft, and he just happened to be healing faster. So I said, cool, you're beating the average. We can get you into a boot sooner. He was happy about that. So that's about it, guys. I'll stick around for a few minutes afterward, eat the cookies or something you guys didn't eat, and answer any questions if you guys have any that you were thinking about during the presentation. But hey, I appreciate you coming. Thanks for paying attention. Hopefully I wasn't, giving you any information out like a fire hose. So once again, thank you for coming. That's the end of the presentation.